The Evergreen Media Network Studio, powered by Scott Tree Services.
Hi, welcome to the Preventus Podcast, everybody. We talk about all things health and wellness with a focus on prevention. This is Dr. Felice Haake, and I'm with Dr. Brett Haake, and we are going to complete our series on advanced cardiac profiles, which are essentially cholesterol panels that take a deeper dive, which is what we do at RBI. And actually, you're representing RBI pretty well with your hat today. Thank you. Thank you. So just to kind of recap, we were talking about how a standard cholesterol panel just doesn't seem to be enough. It's not giving us enough answers, and that half of the females and males that have an actual cardiac event, that they're walking around having no clue that they have coronary artery disease until their first event, which is either a heart attack, which you're lucky to survive, to be honest. A lot of people, it's a massive heart attack and that's it, versus a heart attack where they actually do survive, maybe end up with stents or a bypass, and or angina, which is unstable or stable chest pain.
Well, and you bring up a great point. A couple things is that even if let's say you survive your first event, now you're looking at a heart that's been damaged. And
right.
So the downstream effects of that are you can lose some of the muscularity of the heart. We call that the ejection fraction. You can lose exercise tolerance. So there's a lot of morbidity that is associated with advanced coronary artery disease. And when we talk about longevity, which, in the United States, let's face it, we lag when it comes to other industrialized nations and life expectancy at birth, some of these things. When you talk about longevity, we also want to talk about health span, which is the years of life that you live where you have a high quality of life. So I think it's important as physicians to understand coronary artery disease and understand the way that it develops. And then the second piece of that is that, when you're looking at the conventional lipid panel in your conventional labs, you're exactly right. That may not be enough, number one. And then the second thing is that you're not necessarily, you want things to be optimal, and you're not looking at data points in isolation. So we mentioned this a little bit last time. One of the things I think that you and I have both seen is you might have somebody that's very metabolically healthy and very muscular, and they don't have a lot of insulin resistance, and their fasting glucoses in the morning might be up over that 85 number, which is sort of where we sort of draw that cut. They may be 95. Well, if their fasting glucose is 95, but their A1C is appropriate, their insulin level is appropriately low, their C-peptide, some of these other things that we look at are all okay, well then that 95 isn't as big of an alarm as, say, somebody that has that elevated triglyceride to HDL ratio, that has an elevated fasting insulin, that perhaps has an elevated ALT. So we're looking at data, and one of the things we do is integrate the data.
Yeah,
okay.
That's so important. I mean, I can't tell you how many times I've had a patient sitting in front of me, woman who works out every day. She looks super fit. We have an in-body scale in our office so we can see body composition, and I can see she's got a low body fat percentage, maybe it's like 20%, yet her sugar was like 96. She doesn't fit the picture for insulin resistance. Right. Okay, so It's really important to kind of gather all that information. Hemoglobin A1C, Dr. Brett alluded to, that is a marker for diabetes. That's something that we check. Unfortunately, it's a little bit of a late stage finding for diabetes. It's kind of like the last stage. You'll usually see sugar numbers rise, insulin numbers rise before the hemoglobin A1C. But just to kind of get back to the cardio IQ, which is the Cleveland Heart Labs and Quest's way of looking at advanced cholesterol panels, I wanted to break it apart. So a patient in our office comes in, and we did get this on pretty much everyone. And to be very honest, the next question we always get is it covered by insurance? Medicare actually covers a cardio IQ 4 times a year. I mean, that's pretty impressive. And so, all the other insurances like to kind of follow what Medicare does. They kind of follow suit. So you can be rest assured it will more than likely be covered with your insurance. So it's a really great panel. And I'm going to break it down in terms of what each part of the panel is, and then we're going to go through why we're looking at that. So I know we started in series 1 talking about the first part of the panel is a standard cholesterol panel. That's what pretty much anyone listening, if they've had basic labs, has had. Cholesterol, HDL, triglycerides, LDL. Okay, so that's the first part. Then the next part of the panel is particle sizes. So we start looking at the size of the HDL, the size of the LDL. Are they small? Are they medium? Okay, we're going to get into that. Next part of the panel is called apolipoprotein. So it's looking at ApoB and it's looking at lipoprotein little a, which is a genetic marker, which we'll talk about. But these are little proteins, the way I describe them. I like how Dr. Brett said they're like snake-like proteins that clip onto the LDL. That's exactly what they are. And if you see them, like you see a visual of them, maybe we can give a visual for our YouTube channel, you'll understand them.
Yeah, if anybody if you Google LDL particle, you'll see the makeup of the LDL. Like we said before, it's amphipathic. That means it's hydrophilic. It likes water on the outside. It likes fat on the inside. It's lipophilic on the inside. So it's got cholesterol ester and triglycerides on the inside. On the outside, it's got free cholesterol, phospholipids, and then this snake-like structure that wraps around the particle, and that's called ApoB. So we look at ApoB as part of our advanced cardiovascular lipid panel because LDL cholesterol doesn't tell the whole story about ApoB, and it's the 4 ApoB containing particles that can all give you atherosclerotic plaque. So what does that mean? It means that ApoB is probably a better marker for need to treat as far as lowering your LDL or lowering your ApoB burden, and it's probably a better marker for your response to treatment.
Yeah. Okay. And then just to complete the panel, so that's the first 3 parts, and then fourth part is inflammatory markers, where we look at, is it 5 or 6? 6 inflammatory markers. Six inflammatory markers that look at inflammation in the body, because let me tell you something, that's the big name of the game here, is how much inflammation is going on. And then the last part is a metabolic panel, which looks at your insulin number, a C-peptide, which looks at how the pancreas is sort of secreting insulin, how hard it's working, and an insulin score, which I tell my patients is if you think of insulin resistance on a spectrum, like sort of like autism is, the score shows you where on the spectrum you are. And I just have to share with you a funny story that happened literally today. A patient's score came up as not calculated, and my nurse came to me and said, "Oh, this patient has to go back to the lab. They didn't draw this." And I said, "No, that's actually the best score you can get. Not calculated means the patient has no identifiable insulin resistance." So she was alarmed because we never see that.
Patient is very metabolically healthy.
Incredibly.
And her body is very insulin sensitive. And just to underscore the point, I know we hit on this a lot, but insulin resistance affects the fat cells. It affects the hepatocytes, so the liver cells. It affects the muscle cells. It's very, very deleterious to endothelial cells, which are the cells that line the blood vessels, and it actually affects the brain. And so insulin resistance in the chronic setting is related to depression, anxiety. It can exacerbate PTSD, and then downstream it's actually related to Alzheimer's disease, which is now why Alzheimer's disease is being referred to as type 3 diabetes. So when you talk about prevention and you talk about the big problems that are, lead to chronic disease, things like diabetes, things like what we're talking about today, vascular disease, things like dementia, a big part of preventing those things from happening is ensuring that you're metabolically healthy.
Yeah.
And taking steps to make sure that the patient is metabolically healthy.
Which you can go back to our first 3 podcasts, because we get into the weeds with that as well.
Yep.
So, and then the last little part is just your omega index, kind of looking at omega-3s and their importance, which we'll touch on. I know that's one of your favorite subjects.
Well, it's important because I think that when you look at things like the Mediterranean diet, I don't know if there's ever been a study that hasn't showed cardiovascular benefit with the Mediterranean diet. And
True.
I think the primary reasons for why, one of the big reasons for why the Mediterranean diet is so beneficial is because it's so high in omega-3 fatty acids and omega-9 fatty acids. So as part of our cardio IQ lipid panel, we look at omega-3 levels. We look at the ratio of omega-3 to omega-6, which typically the issue is not enough omega-3. It's very rarely do we have to intervene in terms of omega-6. And then we also look at vitamin D levels. And believe it or not, it seems like everybody that comes into our clinic is low in vitamin D and low in omega-3. And those are 2 layups that you can do if you're not getting enough in your diet to supplement with and bring yourself into the more optimal range.
I've even read that like a low vitamin D is a marker for insulin resistance. And I always point it out to my patients that notice where the vitamin D is placed in this panel. It's placed under the metabolic markers. So, okay, so that's kind of our overview of what a cardio IQ lipid panel would look like. And then we've already touched on the standard part, the top part, what everybody's pretty much had drawn at least once in their life. Can you kind of tell us a little bit about the different particle sizes? Why is that important, that part of the panel?
I think that the important thing to know is the particle number is probably the thing that most is associated with risk. Okay, and so that's one of the things we look at as particle number. It seems to be unclear as far as if the density of the particle is actually more related to risk. I think we do look at density, and I think that's something that we need to pay attention to, but I think particle number is a big thing. So in other words, it's very simple. The more ApoB particles you have, the more likely it is that some of them will move into the vascular wall and become oxidized. And so everybody has a specific particle number. With regard to LDL cholesterol, which is measured on the standard living panel, you can reduce your LDL cholesterol through dietary changes and exercise and those kinds of things. One of the other ApoB containing particles that we're going to talk about, which is what we call Lp(a), that is really a plasma test that we get that is a function of how much that allele or gene is putting out. So that's more of a genetic test, and there's not really a lot we can do from a dietary and exercise standpoint to reduce or change that Lp(a). But particle number, I think, is the most important thing that we pay attention to. The lower the particle number, the better. Okay,
so the particle number is part of that second part of the panel, and the sizes. I've always been taught the smaller the LDL, the more likely they can kind of wreak havoc and get lodged inside the wall. Because if you think about heart disease, the problem starts inside the artery wall first, not in the middle. So everyone kind of thinks of it like, oh, it's just a clogging of arteries with, a plaque. And that takes decades
way
to
downstream.
get. Decades. First, it starts in the artery wall. And there's some very good tests that can test for that early on. So that's that part of the panel. Then we get into the apoproteins, like you just said. And we talked about ApoB, and we actually talked on our first series about that pretty in depth, I feel like, and you can, expound on it if you want. But lipoprotein a, that's a genetic risk factor. So I have it, I happen to have it, and I think they believe about 20, I don't think they're 100% sure. There's definitely still a debate, but I think there's about 20% of the population that's a carrier of this. And mine's rather high. What would you tell a patient like me who's walking around, I'm doing everything right, but I was born with this?
Yes. So unbelievable question. And right. So let's talk first about what Lp(a) actually is. So it's capital L, lowercase p, and then lowercase a in parentheses. That's how you identify it when you're writing it out. And what it is it's an LDL cholesterol molecule bound to what's called, to make it even more confusing, an apo(a), okay, via a disulfide bond at, even more nerdy, the Kringle 9 portion of the apo(a). Okay, so why is it problematic? So apo(a) is structurally very similar to a molecule in your body called plasminogen. It's so similar that it will actually bind to what's called the tissue plasminogen activator receptor, okay, which is where typically plasminogen binds to.
And plasminogen's like part of the clotting cascade.
Correct. When plasminogen binds to tissue plasminogen activator, what happens is that it lyses clots. Okay, you get something called tissue plasminogen activator, and that will lyse clots. The problem is when apo(a) binds to that receptor site, you get it shuts down that receptor. So you get, instead of clot lysis, you actually get clot buildup. So it's more pro-atherogenic, pro-thrombotic in that regard.
Essentially stickier.
Yeah. The other problem is that it abnormally moves into the vessel wall, Lp(a), and it abnormally attracts oxidized phospholipids. So the bottom line is that Lp(a) is really, really good at making vascular plaque, which is why people that have an elevated Lp(a) are more predisposed to things like heart attack, stroke, atherosclerotic peripheral vascular disease, and something that we call aortic stenosis, which is the buildup of plaque and calcification around a valve that connects the left side of your heart to your arterial vasculature, and we call that the aortic valve. And when you get aortic stenosis that's advanced, it causes all kinds of problems. So that's what Lp(a) is. And the next question is if it's high, what do you do about it? Well, you bring up a great question. Your level, I think, if you don't mind me telling the audience, is I think it was 288. The upper limit of normal was 75. Total genetic predisposition. There's nothing that you can do from a diet and exercise standpoint to lower it. So what do? Well, you mitigate the other cardiovascular risks first and foremost. And if you look at a graph containing a hazard ratio in somebody that has an Lp(a), what that is that basically what that means is if I took you with all your exact same risk factors, no insulin resistance, no inflammation, no oxidative damage, eat well, controlled ApoB, so your LDL and your other ApoB particles are lower, okay? So your cardiovascular risk is, let's say, at 0.1% or whatever. If somebody like you with a normal LPA is compared to somebody exactly like you with an Lp(a) of 288, your hazard ratio is 2 times higher. So 2 times 0.1 is still very, very low. So the take home from that is you mitigate and control the other cardiovascular risks.
Right.
Okay. Number one. The second thing is it's important to understand someone's Lp(a), because if they also have an elevated LDL cholesterol and they have risk and they're on a statin drug, which may be the appropriate option, okay, or some other type of, but let's say in this, for the sake of my point, they're on a statin drug. Statin drugs will increase the Lp(a) by about 20%.
Wow.
And nobody's really understands why. Because statin drugs, one of the ways that they work is they inhibit an enzyme called HMG coenzyme A reductase. They inhibit that enzyme so that's the production of cholesterol. So the liver responds to that inhibition by upregulating a receptor called the LDL receptor. It binds LDL cholesterol via that receptor and removes those LDL particles from circulation. Thereby, you get a lowering of the LDL cholesterol. So you would think, because Lp(a) is structurally very similar to the LDL cholesterol particle, the same thing would happen with Lp(a). And for whatever reason, the statin drugs increase the concentration of Lp(a).
So when you say statin drugs, you're talking, just for the layperson listening,
Lipitor,
Crestor,
correct.
Yeah.
All the standard like lipid lowering.
So that might not be the best choice for someone with an elevated Lp(a) and elevated LDL, which is
This is a great thing to talk about, and I think I actually just looked at an article this morning. I've talked to a lot of cardiologists about this. It doesn't mean that the statin drug is wrong and say that this. So, for instance, I had 2 patients over the course of the last couple of weeks that came in. One patient, both of them had advanced coronary artery disease. Both of them had LDL cholesterol levels that were controlled. The problem with their management is no one had ever assessed or addressed their insulin resistance. One guy, in one guy's case, they waited for him to gain a lot of weight. Now he's got diabetes. The other guy no one had ever talked to him about insulin resistance. And even though he doesn't meet the criteria for diabetes, he's got a profound amount of insulin resistance. And then in conjunction with that, they're both on statin drugs, which in their case is appropriate because they had high LDL cholesterols. They had events, so now you want to control the LDL cholesterol, but they also have elevated Lp(a). So in that case, one of the things to do, again, mitigate the other cardiovascular risk. There is a medication right now called the PCSK9 inhibitor, which is specifically lowers LDL, but it will also decrease the Lp(a) by about 25 to 30%. So that's a nice option. Medication. And the PCSK9 inhibitor is basically just a inhibitor of something called PCSK9. PCSK9 is an enzyme that essentially degrades the LDL receptor. So people that are hyperfunctioning genetically for PCSK9 have lower LDL receptors. They have their phenotypically, meaning they manifest with higher LDL cholesterol. People that are low functioning for the PCSK9 genetically have more amounts of LDL receptors, and so they have lower circulating LDL cholesterol. So what we found with these people is that if we can develop a drug that inhibits the PCSK9 inhibitor, we can use that to lower the ApoB burden, and in that drug's case, it also also lowers the LP(a), and the data on the PCSK9 inhibitors is really reassuring.
Yeah, so the brand name for that is Repatha, and I think it's an every 2-week subcutaneous injection. Hard to get covered by insurance. I hate to like bring up the reality, because it's a really great drug. It has a lot of value for the person with elevated LP(a).
There are also other ones. There's one that you can use one time a month, and then there's one that's, I think, approved that you can use once every 6 months. There's a new one. And then there's also a drug that's in the docket for approval, very close, and that drug is called an antisense oligonucleotide, and that drug actually goes into the messenger RNA inside the hepatocyte and basically inhibits the production of that apo(a) so that it can't combine to the LDL cholesterol, and so as a consequence you can't make LP(a). So that's very close to being developed, and I think that drug's going to be a game changer.
I do too. I've been listening to that drug up and coming for years. I actually think, like, as we say, statins is such a colloquial term now. We're going to say ASOs. That's what they're going to be called. They're like a class called just ASOs. And they're going to be great for people like myself. Although I do say to my patients, like you said, I have a pretty low risk because all my other risk factors are low. I do say to my patients who have an elevated LP(a), they get very nervous. Oh my gosh, am I destined to a heart attack? Am I destined to some valvular issues? I say, no, I want you to think of this as you and I have started a race, because I like to let them know I have it too. There's some nice, feelings, fuzzy feelings you get when someone else is in misery with you. So I tell them, pretend like you're starting a race and we're behind everybody. We actually have to catch up. So it doesn't mean we're going to lose the race. We just have to work harder to win the race.
Well, and it's also important to understand if your LP(a) is not detectable or less than 10 or super low, but all your other risk factors, you're going to develop coronary artery disease. If your LP(a) is high and you've mitigated all the other risk, it doesn't mean that you're going to develop coronary artery disease. It's just something to understand. And this is what we're all about, is understanding risk and understanding the way that the disease develops so you can prevent it, or at least delay the onset.
Yeah. So I just think it's such an important factor, because most people listening are probably like, wow, I've never had that checked. Never. And I think it really needs to become standard in terms of our basic labs, So, okay, so following forward, I would love to touch on, while we have a little few minutes left, on omega-3s and their importance. That's kind of what we classically think of as fish oils and what we get from fatty fish.
Right. So our diets, unfortunately, in the United States are oftentimes very low in omega-3 fatty acids. So when you think about the introduction of high fructose corn syrup into the United States and the consequence of that, which is basically ubiquitous insulin resistance and obesity and all the downstream effects of that, which is diabetes, hypertension, renal disease, coronary artery disease, et cetera. The downstream effect, the what happens when you consume high fructose corn syrup is ultimately you shunt into something called the fructose polyol pathway, which results in the deposition of uric acid into the cell, and specifically what we call the endoplasmic reticulum and then the nucleus of the cell. It's toxic to the mitochondria, this uric acid. What the omega-3 fatty acids do is they seem to counteract all of that.
Wow.
Okay. So when the way that your body works is that, and stop me if I start nerding out here, but basically the way your body works is you have DNA in your nucleus of your cell. Messenger RNA comes up, splices the DNA, interprets that genetic information. So now the messenger RNA has that genetic information, moves out of the nucleus of the cell into an area called the endoplasmic reticulum. And inside the endoplasmic reticulum, you have basically these bodies called ribosomes. Ribosomes have deposits of what we call transfer RNA, and inside where you have the transfer RNA, they have containers where you have depositions of amino acids. So the messenger RNA moves through the ribosome, and it basically, the transfer RNA interprets the messenger RNA and you get the production of proteins. So this transfer RNA needs a continuous supply of ATP from the mitochondria. So the relationship between that and the mitochondria is important. The omega-3 fatty acids reinforce what we call the mitochondrial endoplasmic reticulum membrane. So they basically make your messenger RNA and your ribosomes more efficient, which is why every study that we've ever looked at shows that the omega-3 fatty acids are not only heart healthy, but they're beneficial in all kinds of other realms within the body.
They actually help with insulin sensitivity.
Exactly.
Yeah, that's really interesting. I always tell patients, if you know anyone or you yourself have gout, you have insulin resistance until proven otherwise. Everyone thinks of gout as uric acid. So, okay, I really truly believed that we could do this in 2 podcasts, but I am now under the impression we're going to hit number 3.
I think we got to talk a little more about some of the specifics of layman's terms about what omega-3s do, and then let's talk a little bit about the rest of the cardio IQ lipid panel.
I agree, and I also think we need to talk a little bit on how do you apply this to your life.
Exactly.
I mean, at the end of the day, I'm always like, what's the application to me? Okay, there will be a series 3 on this, and so thank you so much for joining us. We had fun.